quick intro, like I said, from MedSoc before we hand over to MedStop. We're really happy to continue to support MedStop. There's a few more essential investigation series sessions that are coming up, and they'll be really useful in the run up to exams, for especially a lot of the younger years and the clinical years. So I think there's a few more endocrinology and other sessions coming up. So keep an eye on the Facebook pages and look out for the events about these sessions. Just a reminder that the UEA MedSoc elections are happening. Details are found on the UEA MedSoc Facebook page. So it's a good opportunity to go for a number of different roles that are open. And another reminder that the resources on the UEA MedSoc team are free, available to use for anyone. We've got notes week by week for the UEA syllabus, but it's applicable to everyone. Here's some examples from a respiratory module, but of course you can see we've got things on dermatology, hematology, respiratory, all the way to psychiatry, emergency medicine, and even SJT and PSA revision. So they're all free to use. And we definitely recommend going on the website and having a look at them because hopefully they can help you with your revision. Additionally, social events for Norwich medics. We're hoping to get some events going, especially Doctor's Mess, as soon as the guidance permits it, and it's the most sort of appropriate way to do it. So keep an eye out on the social media for this. And stash, there's a huge range of stash available for Norwich Med School stash. And it's really been expanded upon as an online shop this year. So more details, of course, on our social media, so keep an eye out for that. Scrubs, hopefully some more scrub sales will go out, but most people should have theirs who have bought some already. These can be worn on clinical placements, especially in our rotation 3 and up to the end of years, as well as for internal electives as your 5th years at the hospitals that were placed at. And the MedSoc and also MedStop YouTube accounts will hold all of the events that we've run over the last couple of months, as well as all freshers events for UEA medics to get an idea of, and also get a refresher of for next year as well. So I won't take up any more of your time. I'll hand over to the MedSoc team to deliver another excellent and really useful session today.
Thanks a lot, Rory. I'm going to start sharing my screen. Okay.
Yeah, it's coming up now.
Okay, perfect.
But we can see your presenter now.
Yeah, I'm just going to adjust it so you can't.
Yeah, all good now.
Yeah? Oh, that was stressful. Okay. Right, guys. So my name is Arjun, one of the final year medical students at Cambridge, and one of the members of MedStop. And we're just a group of final year medical students at Cambridge who have decided to create a teaching course based on interpreting investigations. And we're so lucky to have collaborated with UEA MedSoc as well. And they're helping us advertise our events. So today we're going to talk about interpreting liver function tests. So I'm going to provide a simple but useful framework to approach these tests and go through them in different clinical contexts, which hopefully come up in exams. So let's get started straight away. Okay. Have a go at this SBA and comment in the chat about what you think you need to know further, and I'll respond and see what happens. I'll give you guys maybe 20 seconds. That's really good. So AT's got some good comments. Exactly. So everyone's kind of going along with the pain, so we need to know a bit more about the pain. So this patient is relatively young, 38-year-old male with 2-week history of abdominal pain. So we need to screen for the pain, definitely. So you can use Socrates for that. Alcohol history is very important as well. CIBH. Not sure what CIBH is. Palate, yeah, other symptoms as well. So we need to ask a bit more about the pain. So site, onset, character, radiation, associated timing, exacerbating and relieving factors and severity. So that's an acronym you guys can use for pain. Past medical history. So this is important in the context of alcoholic liver disease as well as fatty liver and viral hepatitis as well. Yeah, medications. So just going through the whole history, medication is important for any hepatotoxic drugs as well as any issues of overdosing, such as acetaminophen, like paracetamol. And family histories are helpful. Alcohol consumption, as someone already suggested, and risk factors for viral hepatitis, including travel history. So then, the reason why I kind of started off with this is because when you interpret blood tests, you should always use the clinical context as a collateral. So you should never take it as a single element. It's important to take a full history. Okay, so you find out a bit more about the history. The pain is constant and progressive. Have a read and comment in the chat about what you're going to do next. Give you guys 20 seconds. Thanks, Sarah. Changing our habits. Okay, CIBH, good to know. Okay, so, yep, so someone's mentioned me privately. So yeah, we're going to do some investigations first of all, but we need to examine them properly. So in terms of what we've found so far, we found that his pain is located in the right upper quadrant and quite severe now. So in terms of the location of the pain, we can narrow it down to a few differentials based on the location itself. So we're thinking it could be liver related to hepatitis, it could also be related to gallbladder and the biliary tree. So it could be cholangitis, cholecystitis, could also be related to the bowel, so IBD, IBS. But with the history of jaundice, we have to narrow it down further. We also have a history of alcohol. So he drinks 2 pints of beer every evening, but there's only 14 units per week, approximately, depending on how big. A bit more than 14. So it's not too worrying. But then we look at the travel history, and he's emigrated from South Africa. So that gives us some kind of indication about the cases or different conditions that you see in South Africa. For example, in this case, viral hepatitis could be quite significant, as well as other hemolytic conditions, such as G6PD deficiencies and so on. You examine him and you find that he has jaundice and he's tended the right upper quadrant. In terms of his observations, he's got a temperature. So you want to do some blood tests, and this is the main thing of the lecture. So we order some LFTs as well as other bloods, and this is what you find. Okay, so you also find raised white cells, and you want to create the poll. So what is the appropriate next step in management based on these LFTs? Give you guys 30 seconds to answer. Ten seconds left. Get your answers in. 5 seconds. Okay. Interesting results. So we have a lot of people going for the screening for the viral hepatitis and autoantibodies, and that is in part correct. We will do that, but in terms of the question, the most appropriate next step. So this is, I can understand why people go for both. Sharing. So in this case, it would be to provide analgesia. But in practice, you would perform the screening and the analgesia at the same time. But in terms of the SBA question, it's important to address the patient needs appropriately. The patient has 8 out of 10 pain, and if we're waiting for the blood results to come back, or you're going to do the blood results, you're not giving any pain relief. You want to address the patient's needs first, and that's why that's the first answer. Okay. In terms of pain relief, there's also a bit of issues because they have liver dysfunction caused by seen by the raised aminotransferases. So you have to be careful when you prescribe analgesia. The paracetamol should be avoided in moderate or severe liver impairment. But ibuprofen has been known to be used with senior advice. So we can give ibuprofen with senior advice. So that's that question. We're going to talk a bit more about the results itself and try and work out why it's so high and what this means as well. But in order to understand how to interpret liver function tests, we need to have a quick run through on the functions of the liver. So this is back to basic anatomy and basic functions. So we'll keep it simple. So the main functions include energy metabolism, so glycolysis and fats. We also have synthesis, in particular albumin synthesis. And this is important because albumin is one of the factors that can be measured in a liver function test. So a reduction in albumin could be related to a reduced synthesis and therefore impairment in liver function. Regulation, storage, and detoxification. In particular, bilirubin. So bilirubin has to be conjugated in the liver by UDP, glucorenoside transferase. So we need to be aware of that in case there is changes in bilirubin, which can be related to liver dysfunction. And we'll talk a bit more about that in detail. Okay. So these are the liver function tests. You probably have come across them before, but if you haven't, we can divide them into 3 categories in order to make it easier to understand. So we have the aminotransferases or transaminases. These are alanine and aspartate, and they are related to hepatocellular damage. We have alkaline phosphatase and gamma glutamate transferase and bilirubin, which are related to cholestasis, and total protein, albumin, and prothrombin time, which are related to synthesis. And we'll talk a bit more about each one. Okay, so first of all, hepatocellular damage. What does that mean? So the enzymes ALT and AST are just enzymes that are involved in the gluconeogenesis pathway, and they catalyze transfer of an amino group. So they form pyruvate and oxaloacetate respectively. But why are they relevant? So in terms of where they are, the enzymes are located in the cells of the hepatocyte. So in any type of injury that causes the endothelium to be disrupted, the enzymes are released into the blood, and that's why you get a raised ALT and AST in any type of hepatocellular injury. And it's really easy to measure as well. So ALT is specific to the liver, but AST is non-specific, so it's also located in heart muscle, skeletal tissue, kidneys, brain, pancreas, lungs, and red blood cells. So that's helpful, but also it's non-specific as well. In terms of how we measure them, so there's 2 different ways. So we have to look at the level, and we have to look at the ratio. So the level is based on if it's a large increase, so it's a high 100 to 1,000, which narrows down our differentials to certain conditions, including viral hepatitis, drug-induced, such as paracetamol overdose, ischemic hepatitis, and autoimmune hepatitis. In these conditions, they can also cause something called acute liver failure or fulminant hepatitis, which is characterized by coagulopathy and hepatic encephalopathy. So coagulopathy is basically a disruption in the clotting factors, which can be seen by a rise in prothrombin time and hepatic encephalopathy. Yeah, so the slides I think we'll put on the PowerPoint slides on the YouTube channel at some point, hopefully. Okay, so in terms of the ratio, that's another thing we need to look at. So the ratio between AST to ALT is important in the context of, in particular, alcoholic hepatitis, which most people are aware of. So they know that there's a 2-to-1 ratio of an increased AST to ALT, but it's also important to be aware that ALT is higher than AST in viral hepatitis, fatty liver, and cholestasis. So we talked a bit about hepatocellular damage and the different conditions that can lead to damage. Now we'll talk a bit about cholestasis. And for those who don't know, so cholestasis comes from the Greek, comes from chole, which means bile, and stasis, which means still. So the condition where the bile is still. And this can be in 3 different ways. So it can happen either through an impaired bile secretion or production. It can be due to biliary obstruction within the liver, or biliary obstruction between the liver and the duodenum, so extrahepatically. And this is helpful because so in terms of what happens is that the patients generally have symptoms of jaundice due to conjugated bilirubinemia, pale stools, dark urine, and symptoms of fat malabsorption as well due to the reduced bile in the gut. So we'll talk a bit more about why that happens, going to the bilirubin cycle as well. So to make sure we understand that. But the relevance to the liver function test for cholestasis is that cholestasis induces the production of alkaline phosphatase and GGT and gamma-glutamyl transferase, because any changes in bile disrupt these proteins, which are found on the apical membrane of the cells, and these are released directly into the blood. So I'll click that. So ALP is a isoenzyme, which is basically the same enzyme that's found in the liver, bones, placenta, and kidneys, which means that it's non-specific to the liver. So this arises both in cholestasis, but in other conditions, such as osteoblastic activity, for example, bone met, osteomalacia, Paget's disease, and also during physiological growth periods, but also arises during pregnancy. So the thing to be aware of that if you see a rise in ALP, it doesn't necessarily mean it's related to the liver. You should have a look at GGT as well and bilirubin. So GGT is more specific and rises in liver cholestasis, but also in alcohol use. So in some ways, you can actually narrow down a differential to an alcohol-related hepatic problem if there is a significant rise in GGT. It's not elevated in bone disease, hence it's more specific. Bilirubin is a protein that is made from, well, from the breakdowns of heme, and can be divided into unconjugated and conjugated, which can be measured by direct or by the total serum bilirubin, as well as a direct bilirubin. So in terms of what conjugated bilirubin simply means, we'll talk a bit more about how it's made, but it's the same as direct bilirubin, and unconjugated bilirubin is the same as indirect bilirubin. Okay, so the main things we need to be aware of in terms of cholestasis is extrahepatically gallstones and tumors, intrahepatically hepatitis and drugs, which can cause a rise in these variables. But before we talk a bit more about the conditions, I want to just explain the bilirubin cycle, which will help understand why we get these changes and also understand the relevance to the clinical context. So normally, red blood cells cycle around for 100 to 120 days until they're broken down in the spleen by the macrophages, where they break heme into unconjugated bilirubin over here. So unconjugated bilirubin is not soluble in water, so it's not able to be excreted from the body. In order to excrete it, it needs to be conjugated within the liver. And this takes place using enzyme, the UGT glucuronosyl transferase. And this conjugated bilirubin is happy to go back to the bloodstream, be excreted in urine by urobilin because it's now water soluble. Most of it, however, passes through the hepatic duct, through the common bile duct to the common bile duct and into the intestines to form stercobilin, which gives the feces the brown color. So this is what normally happens, and any deficiencies in enzyme can also cause problems later on. So in terms of the relevance to our pathology, any type of obstruction can prevent the conjugated bilirubin passing through the common bile duct towards the intestines, and therefore it flows back into the liver and towards the bloodstream. So you have a rise in the conjugated bilirubin in the blood, and this is excreted in the urine. So the relevance of this is that the conjugated bilirubin causes patients to have this the jaundice, which can be seen by scleral icterus, so the yellow of the eyes, and you get darker urine as well. You also get paler stools because there's less stercobilin in the stools, which is also relevant for the symptoms. So conditions which cause obstruction can be either intrinsic, so for example, a gallstone, or it can be extrinsic, so for example, a compressing tumor, either from the hepatic side or from the pancreas, or it can be related to inflammation of the duct in primary biliary cholangitis or primary sclerosing cholangitis. So there's a few differentials which help us go back to this in the bilirubin. So a rise in conjugated bilirubin we talked about is due to cholestasis. This can be divided into extrahepatic, intrahepatic, or secretion. The most common ones you need to be aware of are gallstones, tumors, hepatitis, and drugs. Okay, a rise in unconjugated bilirubin, and this is when it doesn't go to the liver, either through a defect in the enzyme itself, so defect in the conjugation, such as Gilbert syndrome, or an overproduction of unconjugated bilirubin due to increased breakdown, such as in a hemolytic picture. So you have a few different types of hemolysis which require further investigation, but I'm not going to go into that in this detail. We're going to go through hemolysis in another presentation. Okay, so I'm not going to go into too much detail about the conditions, but that's the main picture that we need to be aware of. So finally, hepatic synthesis. So the previous two categories only measure acute changes to liver function, and it doesn't really measure like a chronic condition which can cause dysfunction. So cirrhosis is one of the chronic conditions that can cause reduced hepatic synthesis in one of the functions. And this is important because we'll talk about albumin. So albumin is produced, as we talked about, in the liver. So you have a reduction in albumin in a defect in the synthesis, in cirrhosis, for example. And because albumin produces, is part of the transport proteins and makes up most of the proteins in the blood, it maintains osmotic pressure, and it's very important in doing this. And it's produced exclusively in the liver as well. But at the same time, just because you have a reduction in albumin doesn't necessarily mean that it's related to the liver. So you can have other conditions which can cause a reduction in albumin, such as nephrotic syndrome, protein-losing enteropathies like celiac disease, Crohn's, UC, or malnutrition. Prothrombin and INR are two other variables that can be used to measure hepatic synthesis. So what is prothrombin time? It's basically the time it takes to produce fibrin polymers after adding thromboplastin and calcium. So it's just a set time that they use, and it's normally around 11 to 15 seconds. So they measure the extrinsic pathway and the common pathway in the clotting cascade, if you can remember back to that. So the way I remember the extrinsic pathway is 1972, so that's factors 10, 9, 7, 2, and the common pathway is factors 10, cofactor 5, thrombin and fibrinogen. So these rise when there's impaired hepatic production of clotting factors, for example, seen in cirrhosis, but it's also not specific to just cirrhosis because it is related to the other enzymes and factors in the clotting cascade, including vitamin K deficiency, factor 7 deficiency, and disseminated intravascular coagulation. INR, if you might have seen in clinical practice, is used to monitor warfarin efficacy. So when patients are on warfarin, because it's a blood thinner, it's I think it's a vitamin K antagonist. So it basically reduces clotting factor activation and increases the bleeding time and raises PT. So we use INR to measure how effective warfarin is, and we want to put it between 2.5 to 3.5, depending on the clinical indications. Platelets are also reduced in liver cirrhosis, but it's not specific to this condition, obviously. Okay, so in terms of the summary, we talked a bit about the three main categories. We just need to be aware of what each of the variables that we measure correspond to, and that's this take-home message. So we're going to apply these principles to the next different questions. But before we do, just the important factor of levels of ALT and AST is important as well, particularly just related to the high levels correspond to, as we mentioned, viral hepatitis, ischemic hepatitis, and drug-induced, for example, acetaminophen overdose. And lower levels correspond to chronic viral hepatitis, fatty liver, and alcoholic hepatitis. So just to be aware of for the levels as well. In terms of the acute liver, in terms of other things you need to be aware of, according to guidelines, if the ALT, AST levels are above 300, you should perform an acute liver screen. However, if it's just above 150 but below 300, you can just repeat the LFTs in 2 weeks. Okay, so we're going to apply these principles to the SBA that we talked about. So we can see that these three categories are highlighted, well, two categories in this context. And this is a mixed hepatic cellular damage and cholestatic picture with ALT levels above 1,000. So it's a differential we talked about, and the ratio is approximately 1. And we can only see a mildly based GDT, so alcoholic hepatitis is less likely. Okay, so you prescribe an acute ibuprofen, you perform an acute liver screen panel. So what is an acute liver screen panel? This is basically what we have to do when we think about if there's any causes of hepatitis, any dysfunction in the liver. We have to screen for any causes. So in particular, the history is important. we also need to think about viral infections, so hepatitis B, which we talked about in this context, C, Hep P, as well as CMV, EBV, and HSV, HIV. We also have to think about liver autoantibodies, in particular for autoimmune hepatitis, PBC, and PSC, and risk factors for fatty liver, so lipids and glucose. Metabolic conditions, so 3 main conditions you should be aware of for liver problems are hemochromatosis. That's a condition where there's abnormal iron deposition in the specific organs, causing race ferritin and race transferrin. Wilson's disease, an autosomal recessive condition where there's impaired copper excretion, causing a race-free serum of copper, but reduced ceruloplasmin, which is a transport protein. And you also have increased 24-hour urinary copper. And finally, alpha-1 antitrypsin deficiency, which is basically a condition where patients have reduced levels of alpha-1 antitrypsin, so there's increased protease activity in the lungs, and you get young patients with emphysema, classically pan-acinar emphysema, so it's a good risk differential to have if you have a young patient with COPD, well, COPD picture. And finally, liver tumor can be identified using ultrasound scans, but you can also identify liver cysts as well as hemangiomas and other benign pathologies. Okay, so we did the acute liver panel, and most of it came back negative, except from this. So I'm going to put up another poll now because I've been talking for a while. You guys can have a go. Okay, I'll give you guys 30 seconds to have a go. Maybe 40 seconds, sorry. Okay. 10 seconds left. Okay, I'm going to 5 seconds. 4, 3, 2, 1. Okay. So most of you did get it right, with the majority of you that voted, but I can understand it's a difficult question. So we'll go through it and try and work out why it is first presentation acute hepatitis B. Okay. So the way I do it, and a lot of people do it as well, one way of doing it is I look at the Hep B surface antigen. So this is basically the first protein that you see in an infection. It's a protein on the surface of the hepatitis B virus, and it's the first evidence of infection. So this could be either acute or chronic. So the fact that this is positive means that there is an infection currently happening. So this could be either an acute infection or a chronic infection. So we know there's an infection. So then we move on to the anti-hepatitis B surface antibody, which is the antibody to the surface protein. This takes approximately 1 to 3 months to appear after either infection or vaccination. The fact that it's negative means that they definitely haven't been vaccinated, or the vaccination has been effective. And if there is a current infection, they haven't had enough time to develop the immunity, or they are in a chronic infection and they're unable to develop the immunity. So in either case, there's an infection and they're not immune to it currently. So we know there's an infection currently, but they're not immune to it. Then we look at the anti-HBC. So this is the core antibody. This is the core antibody to the core protein. And this is positive. So then we can find out if it's a long-term or short-term antibodies which are present. So IgG is the long-term antibodies. IgM is the short-term antibodies. So the way I remember it, the way someone told me was M is not for memory, which is a bit different to how people can remember. But M is not for memory, so it's a short-term antibody, and G is a long-term antibody. So the fact that the memory antibody, sorry, the acute antibody is positive means that there's an acute or recent hepatitis B infection, and it's present for 6 months. If the IgG antibody was positive, that would mean there's either a long-term resolved or chronic infection or a previous infection. So the fact that this is negative means that there is no chronic or previous infection. So IgG anti-HBC negative, so there's no previous or chronic infection. And that's why this has to be the first presentation, and there's an infection, so it's acute hepatitis B infection. Okay, does that make sense? Let me know if it doesn't, I can try and go back over it. Okay, so in terms of the management, the main principles are conservative, medical, and surgical. So that's how we manage most things. Conservatively, the main things you need to take home from this is that any acute viral hepatitis is a notifiable disease, which means you have to notify the proper officer at the health protection team. You should also perform contact tracing as well for hepatitis B vaccinations for anyone who's been in contact. In terms of medical treatment, which is often used, pegylated interferon alpha, which may be an SBA answer, may be used in hepatitis B. There's other conditions, other antivirals as well. The surgical option includes liver transplant, but this is usually for a last resort. For acute liver failure, as we talked about, it involves coagulopathy, jaundice, and encephalopathy. Okay, so this patient's fine and he's back on his feet. So we've now found an older patient. I'll let you guys have a go at this. It's a little bit more information. But let me just see. Okay, yeah. So you can just write in the chat what you guys think. Open to anything, open to discussion. I'll give you guys 40 seconds. So I think Becky has said, what were the levels you need to do for the acute liver panel? So in terms of some guidelines that I've seen online, for example, Eastern Liver Net have very good referral pathway guidelines. They said that you should perform an acute liver panel for anything above 300 for ALT levels. But I think you should look at the local hospital guidelines to be sure as well. Okay, so anyone want to suggest what your differentials are for this? Good, we got alcoholic liver disease is strong, yep. Since from the history, alk-hep, good. Yeah, I think most people have got it. So in terms of what's going on, so we're looking at the history. It's an older patient, he's not feeling great and he's looking a bit jaundiced. He's gained a bit of weight recently. You're like, what's going on here? Then we find out later on there's abdominal distension, shifting dullness. So this is probably related to the ascites. There's no abdominal pain, no fever, and he drinks quite a lot of alcohol. So there's definitely at risk of alcoholic hepatitis and alcoholic-related liver disease. In terms of on examination, he's jaundiced, he's got a raised JVP, so there's some type of obstructive picture going on, probably related to cirrhosis, causing portal hypertension. A palpable mass in the left upper quadrant. So this could be a few differentials, but in this context, I think it's more likely to be a splenomegaly caused by the portal hypertension. He looks malnourished because it's alcohol causing vitamin deficiencies, and there's evidence of bruising on his forearms. So the bruising is related to either a coagulopathy. So here we can see a reduced albumin and an increased prothrombin time causing excessive bleeding. So in terms of the observations, there's nothing that's worrying. In terms of the liver function test, so we have a look at that. So we can see if you divide it into the three categories we talked about, there's a mixed hepatocellular damage, so everything is raised or abnormal. So there's mixed hepatocellular damage, cholestatic and synthetic dysfunction. The levels are relatively lower, so it's into low hundreds. So we're thinking more of a chronic picture, so chronic viral hepatitis, fatty liver, alcoholic hepatitis, cirrhosis, autoimmune. But with the history combined, we can narrow it down more towards alcoholic hepatitis. And then we look at the ratio, the AST to ALT ratio. So this is 2 to 1. And this gives us more of an indication it's alcohol related. So the synthetic dysfunction as well, caused by albumin and PT, indicates that cirrhosis could be likely. In terms of differentials, so this is a classical painless jaundice, but it's not in a lot of people think pancreatic cancer when they think of painless jaundice, but there's other differentials as well to be aware of. So it could also be other tumors, but also could be related to cirrhosis and colic hepatitis. So differentials of ascites is based on the serum ascites albumin gradient, and this can be divided into things that cause portal hypertension and things that cause infection or malignancy. So we talk a bit more about that as well. So we've done our liver function test. We're a bit concerned actually because there's evidence of decompensation. So ascites is evidence of decompensation in a cirrhotic patient. So we're a bit concerned about this. So what we do next is we send the patient to A&E because we're actually concerned about him. Perform an abdominal ultrasound, but a lot of hospitals can do the transient elastography or fibroscan, which diagnoses liver cirrhosis, but you also need to do other investigations. So what is a key investigation in this context, in this presentation, that we need to do to rule out certain conditions? Sorry. I'm trying to move the chart. Okay, I can't move the chart. Yeah. Just message in the chat. What other investigation would you want to do in this context, in this presentation? CT is very useful, yeah. What else? So in terms of what he's presenting with ascites. So we want to do a ascitic tap or a pleurocentesis because spontaneous bacterial peritonitis is a common complication in patients who present with cirrhotic ascites. And it's important to know that these patients may be asymptomatic, so they don't have a fever or abdominal pain. So for this reason, a diagnostic ascites tap should be performed in all patients with cirrhosis and ascites being admitted to hospital. Okay, so we perform a paracentesis, so another way of saying it, ascitic tap. For cytology, so looking at the cells, looking at the number of white blood cells, red blood cells. Culture, so looking for any evidence of bacterial growth, and protein content, so the evidence of albumin. Okay, so these are our, and we find this as our results. This is a bit of a difficult question, but have a go at this. Let me see what you guys think. I'll put up the poll. I think it's poll. Okay. Give you guys 40 seconds. Oh, sorry, I keep moving that. Sorry. Have a go. You've got 20 seconds left. Just have a go. This is a difficult question, and I made it particularly tricky to catch people out. Okay, 5 seconds left. 4, 3, 2, 1. Okay, great. Let's share the results. Okay, wonderful. So we have a range of results with a few people going for the two options in the B and C. Okay, so we'll talk through it, and the correct answer was actually B, but I'll explain why in a bit. Okay. Right. Okay, so the importance of ascites is an importance of an ascitic tap is to allow differentiation between the different types of causes. So we'll talk a bit about the serum ascites albumin gradient. So this is basically serum albumin take away ascites albumin, just taking away like from the values, and this is the gradient. And the reason why this is important is that it helps to characterize the fluid content and the causes of ascites. So the reason why we use the ascites albumin gradient is that it's due to Starling's forces. So the balance between hydrostatic and the oncotic pressure. So normally the serum albumin ascites gradient is less than 11, because the serum oncotic pressure, so that's the fluid pulling back into circulation, is counterbalanced by the hydrostatic pressure, which is the fluid pushing out of the circulatory system. So when there's a change in the hydrostatic pressure, for example, in cirrhosis or heart failure, there's an increase due to obstruction and portal hypertension. There's an increased hydrostatic pressure pushing fluid out into the peritoneal cavity. And that's why you have the fluid leaving the circulatory system and entering the peritoneal cavity due to the raised hydrostatic pressure. And because of this, we have an increased concentration of the protein, because when we lose fluid, the concentration increases. So in situations where there's a raised concentration of the serum albumin ascites gradient, this is due to conditions where there's portal hypertension. For example, in liver cirrhosis, cardiac right heart failure, constrictive pericarditis, as well as thrombotic events such as in Budd-Chiari, which is the hepatic vein thrombosis, or portal vein thrombosis, and other veno-occlusive diseases. Okay, so in the other context, if there's a low serum albumin ascites gradient, then we're thinking it's more related to hyperalbuminemia, so the conditions we talked about before, as well as malignancy and infection. So in particular, spontaneous bacterial peritonitis. Okay, so the relevance for this is seen in the question we talked about. So we looked at the fluid. So the fluid is clear and there's no red blood cells, and white blood cells are, white cells are low. So there's no infection really, there's no signs of bleeding as such. The serum ascites album gradient is 19, so that's above 11, significantly above 11. So we're thinking there is definitely some type of portal hypertension picture. In this case, with the history and the LFTs, probably related to cirrhosis and decompensation causing ascites. In ascites is usually managed by fluid restriction, because in patients with ascites, they are volume overloaded. So we want to reduce the volume by giving them less fluid. And at the same time, this can help by reducing the sodium as well, because this ultimately reduces the hydrostatic pressure, which is what is causing the fluid to leak out into the peritoneal cavity. Spironolactone is an aldosterone antagonist. So if you remember what aldosterone does, it acts on the renin-angiotensin pathway to increase the absorption of sodium and increase the secretion of potassium. The spironolactone basically decreases sodium absorption and basically effectively reduces the hydrostatic pressure to reduce ascites. Differentiating between B and C is difficult. So ciprofloxacin is an antibiotic which has been advocated to be added by NICE as prophylaxis against spontaneous bacterial peritonitis. If patients have an acidic albumin less than 15, have cirrhosis and ascites. So this patient, is a sneaky question, but this patient has cirrhosis, ascites, and an acidic albumin less than 15. So we want to add an antibiotic, a quinolone in particular, so ciprofloxacin is required. So D, you don't want to refer until you've tried some medical management, because a transjugular intrahepatic podophysomic shunt, or a TIPS, is basically bypassing the liver by connecting the hepatic vein, the portal vein to the hepatic vein. So basically reduces the obstructive picture by bypassing it, a bit like the cabbage in the heart. Reassurance, you don't want to just reassure the patient and give them lifestyle intervention, because they're acutely decompensated, so we need to intervene with medical management at least. Okay, and we don't want to give them fluids right now because we need to fluid restrict. Okay. So ciprofloxacin needs to be added when there's patients with cirrhosis, ascites, and an acidic albumin for less than 15, according to NICE guidelines. Okay. That's all right. And okay, so he goes back home. You treat him. He goes back home, but something else happens. So what's happened? What are you going to do? Give you guys 30 seconds. Yeah, so Emma's right. So we have esophageal variceal hemorrhage. And for this, we'll talk a bit more about why that happens in these patients as well. But from the history as well, we can see that they're vomiting bright red blood. So it's an upper GI tract pathology, a bleed anyway. And they have dark stools, so we're thinking it could be melena. So we're still thinking upper GI tract, because if you think about the location of the GI bleed, I can relate to the symptoms as well. So he's got mild abdominal pain, no syncope, no fever. Okay, that's fine. He's jaundiced, got a distension, probably related to this mild ascites as well, looks malnourished. Worryingly, his blood pressure is very low and he's got tachycardia. So he's thinking he could be in a hypovolemic shock caused by varicose hemorrhage. So why does this happen in these patients? And what are you going to do about it? So this is a schematic diagram, very simplistic, of the portosystemic connection. So the left gastric vein normally drains towards, the portal vein drains towards the liver. But in obstructive pictures and cirrhosis, for example, we have a backflow causing portal hypertension. So that's basically a raised blood pressure in the portal vein through the left gastric vein into the collateral esophageal varices. So these are just collateral veins supplying near the esophagus. And then these go backflow into the esophagus veins as well. And the esophagus veins are actually part of the systemic circulation. And this is why portal hypertension eventually causes a portosystemic shunt. And this leads to esophageal variceal bleeding due to the changes in the pressure of these thin friable vessels. So in this picture below, we can see this is a camera picture taken in an OGD. So this is like an esophagogastroduodenoscopy or an upper endoscopy. And this is where we can see dilated variceal vessels with evidence of hemorrhage. And this is classically seen in patients with cirrhosis as well. Another issue is that patients with cirrhosis also have reduction in clotting factor synthesis we talked about. And this means that they're more likely to bleed in a more severe way. So we need to correct the clotting factors as well. So that's part of the management, which we talk about. Okay. So their blood pressure is very low. We need to do an A2E assessment straight away. So in terms of all types of acutely unwell patients, you should approach them in the same way, not panic. Start from A to E. So we want to make sure their airways is secure. So patients who are bleeding from their esophagus, they may have blood in their trachea as well. So if required, we can use intubation to secure the airway. We need to have IV access and give them fluid straight away, stat bolus, because of the hypovolemia. But we also want to give them clotting factor corrections as well. And following local guidelines, we might need to give them packed red blood cells and platelets. Terlipressin is I think it's a ADH analog, which is specific to the splanchnic circulation in the GI tract. So it basically causes vasoconstriction of the vessels and basically reduces the portal pressure. That's usually given under senior advice before we start the endoscopy. IV antibiotics is used as well, ciprofloxacin, because one of the doctors was saying that bacteremia can cause rupture of the varicose veins. So we want to just make sure that that doesn't happen as well. So we give antibiotics. But the definitive treatment is endoscopy with variceal band ligation. And this is basically in the image that we saw previously. We put a camera down and you put some clips or rubber bands across these vessels which are bleeding to stop the bleeding into the esophagus. And you want to do that across all the vessels which are bleeding to make sure that we don't miss any out. And if that doesn't work, and if they have recurrent bleeds, you want to do the tips that we talked about, which is basically bypassing the liver as well. Primary prophylaxis is important as well. So a beta blocker, a non-specific, so propranolol is usually used, or variceal band ligation. So you want to do the operation as well if you can't use propranolol. So the problem with this patient is that they should have had an OGD initially to rule out varices at the diagnosis of cirrhosis. So this may not have happened if they had the screening, and that's what we'll talk a bit more about in terms of management of cirrhosis as well. Okay. So liver cirrhosis is a very common condition characterized by irreversible fibrotic changes. And this can be secondary to a lot of conditions. Things to remember are alcohol-related liver disease, non-alcoholic fatty liver disease, hepatitis B and C are the common ones that we need to be aware of. Clinical features include non-specific features like tiredness and weight loss, but also skin features related to hyperbilirubinemia. So we have jaundice and pruritus, but also portal hypertension features like hypomedusa, which is when you have the dilated veins in the abdomen, as well as ascites. So that's another result of portal hypertension, and hepatosplenomegaly as well. You also get pulmonary edema from increased estrogen synthesis or detoxification as well. And you have petechial pleura from the coagulopathies. Nail clubbing is a non-specific sign of chronic liver disease as well. You have asterixis as well, and fetal hepatitis related to toxin production because the liver is unable to detoxify certain compounds. And basically a sweet but sour breath that you can smell. But I'm not going to go into too much detail on the clinical features. The things to be aware of is that when you do blood tests, particularly FBC, you might have a macrocytic anemia, so you have a raised MCV, and this could be related to alcohol, vitamin B12 deficiency, or folate deficiency, because alcohol can lead to those deficiencies. You also have reduced platelets, deranged LFTs, and diagnosis is based on either FibroScan, but classically a biopsy. Management divided into conservative, medical, and surgical. So conservative is healthy eating and diet, stop alcohol, stop smoking. Medical, adjust medications and give propranolol. Remember, that was important, so we didn't give that. And surgery is paracentesis, ascites, and tips, or liver transplant definitively. In terms of monitoring, we talked about having an upper endoscopy for diagnosis, at the diagnosis to screen for varices, and the liver ultrasound every 6 months, plus minus alpha-fetoprotein, which is raised non-specifically in hepatocellular carcinoma. Okay. Complications, these are the things that we talked about, we saw in the patient. So the patient had 2 types of decompensation. He had ascites and varicose hemorrhage, as well as jaundice for both. But you can also get hepatic encephalopathy. Hepatorenal syndrome is a condition where you get acute dysfunction in kidney related to advanced liver disease, and you also get hepatocellular carcinoma. There's a few others, but these are the main things that you should be aware of. Okay, and I'm just going to finish. In terms of prognostication, so this is basically a tool that clinicians use to predict the likely or expected development of the disease. And the Child-Pugh score is used in liver cirrhosis to help determine the mortality based on the clinical lab reports. So if you have, the main take-home message is that you can see how quickly the mortality rate decreases by just a few variables of increase and decrease. Okay, so that, and also class B or greater is considered an indication for liver transplant or a consideration for liver transplant as well. Okay, just things to be aware of. And I'm going to finish off with this SBA because the time's coming up to 7 p.m. Yeah, I'm going to give you guys a few minutes, 20 seconds, 40 seconds, and I'm going to create the poll. Okay, 40 seconds to answer this. Okay, it's really good. 5 seconds left. 5, 4. 5 and 4. Good. Great. I'm going to end the poll now and share the results. So yeah, most of you actually got it. We got this right because, and you guys should, probably know that this is Gilbert syndrome, or we're thinking it could be Gilbert syndrome. So we'll talk a bit more about what, if you haven't heard of it, we'll talk about what it is and why this is reassurance in education. So in terms of the liver function test, so we have a normal blood test and we just have mild jaundice with everything else normal, and he has no other conditions. You also know that he's been training for a marathon the past few weeks and he's relatively young. He's got an isolated rise in bilirubin, which is also mild. So in terms of what we should be aware of is an isolated rise in bilirubin with other normal tests with no anemia and no signs of hemolysis indicates probable Gilbert syndrome. And this is an inherited condition, as we talked about, that has a defect in the enzyme that is involved with conjugation of bilirubin to conjugate from indirect to direct. So because they can't produce direct bilirubin, there's an increased indirect bilirubin or unconjugated bilirubin in the blood. So this you can measure by looking at the bilirubin and taking away direct bilirubin to work out that the indirect is around 30. So it's more of an indirect rate. So you have a slightly increased indirect bilirubin rate, normal liver function, and there's no evidence of hemolysis. So there's no evidence of LDH, haptoglobulin, or FBC abnormalities. This period, he was exercising heavily, and probably the reason why he experienced this intermittent jaundice. And the management for Gilbert syndrome is reassurance and education. So patients, it's quite common in Western Europe, 5 to 10% of the population are affected, but most cases remain undiagnosed due to the asymptomatic nature of the condition. And by at least 30% of patients with Gilbert never actually develop symptoms. So that's an interesting case to finish off with. And just to summarize, whenever we look at liver function tests, we have to think about the history, which is very key. And then after that, we look at the three main categories. And that will help us differentiate and narrow down our diagnosis as well as our management. So I hope you enjoy that talk, and I hope that all made sense. And sorry for rushing through it. I had to try and get through it to the end. Thank you guys for attending. I really appreciate any feedback you can provide using this link. I think Rory or someone else may want to have a chat afterwards. If not, next week we have our next lecture, which is endocrine part 2. So we'll be talking a bit more about the different abnormalities and interpretations that we need in endocrine itself. And yeah, so follow us on the Facebook page for MedStop to keep in touch, as well as to be aware of any other events that we have coming up. But yeah, hope you guys enjoyed it. Thank you for coming. Rory, do you want me to do anything now?
No, I think that was excellent. Thank you very much for that.
Right.
That was really interesting. I don't know if anyone else from your team's got anything to add or say. I've got nothing from MedSoc to update. But someone's just asked for the URL chat on the chat for the feedback. Is that possible? Oh, there.
I think Ben's
just done it.
Ben. Yeah. Thanks, guys. I appreciate it's Monday evening, so appreciate all the support you guys gave.
Perfect. If you're happy, I'll just end the recording there. Yeah.
Yeah.